Is the third leading cause of cancer deaths in the United States, and experts want it to be first on our minds this coming month. We're talking about colon cancer ahead of Colon Cancer Awareness Month in March with Gunderson gastroenterologist Dr. Steve Shlack-Haerer. Doctor, thanks for joining us this morning, talking about the issue of colon cancer. I mean, third leading cancer-causing death in the U.S., but how big is the scope locally?
Oh, it's big, and again, this is both men and women across that. Still, the second leading cause of cancer death in both men and women. So we're really not talking about an unusual situation. The good news is that it's largely preventable. The time we think it takes to grow from a small polyp to a colon cancer is generally about 8 to 10 years duration in most cases, which gives us a large opportunity to screen for these polyps and actually remove them well before they cause trouble. The downside is that there may or may not be any symptoms at all. The typical symptoms of bleeding, change in the bowel pattern, unexplained weight loss are one thing, but many times it's completely asymptomatic. So we really have to be on the forefront of being aggressive about screening beforehand.
Yeah, and those screenings are something you recommend regularly. What's the age when you want to start seeing people come in?
Right. For average risk individuals, that is no family history of colon cancer or colon polyps, we generally start screening at age 50. If there is a family history, we generally start 40 years of age or 10 years younger than the youngest family member that's affected. Now, we are actually seeing a little bit of an uptick in colon cancer incidence in the age 40 to 50 range, and we're likely to see a push for perhaps even those screenings starting even a little bit earlier than age 50 for average risk individuals.
Talking about screening too, we don't have a lot of time left, but I want to hit on this because it's something we're seeing advertised now. Some of these at-home screening services, devices, things like that. What do you have to say about how do those work?
Well, we're talking primarily about Cologuard, looking for genetic changes that are sloughed off in the intestinal tract and collected in the stool. They're quite accurate for telling us whether people have colon cancer. That is probably better than 90%. Unfortunately, where they fail is when you start looking at the precancerous polyps, especially advanced adenomas, greater than 1 centimeter in size. These are the ones that are the bad players. They're on their way to going there, and unfortunately, they're going to miss the significant majority of those. And so we really have, at this point in time, we still consider colonoscopy to be the best, not only from a diagnostic standpoint, but from a therapeutic standpoint. If we find the polyps, we can remove them. And really with the sedation, really it's not a bad test. There's a lot of misconceptions about colonoscopy. Once people go through it, they really realize and say, boy, that's not nearly what I expected from a negative standpoint.
Yeah, especially given the payoff of catching it early if possible. And Dr. Steve Shlack-Haerer, we thank you for joining us this morning. Of course, wear blue on Friday for Colon Cancer Awareness Month on March 1st. And we'll be right back with the check of your day planner outlook next.